Real quick, I want to touch on this. High lung shunt, what precludes a patient from treatment? Is it lung shunt or lung dose?
Lung dose, and not only lung dose. This is one of the areas we need to highlight the differences between the two devices because of the number of particles.
Absolutely.
And there are published studies on these that radiation pneumonitis can, just like how we get complete response in HCCs with 300 gray as opposed to 1,000 gray or 600 gray with resin compared to glass because of higher number of particles, the biologic effect can be also toxicity that can happen at lower doses. So there's a systematic review that was published 4 or 5 months ago now on JVR looking at all reported, again, we mentioned that all the reported radiation pneumonitis cases in the literature, they have inaccuracies because of the lung shunt fraction with the planar imaging used and the fact that almost all of them assumed a lung volume or lung mass of 1 kilogram, and all of those are inaccurate. But despite all of that, there are radiation pneumonitis reported at lower doses for resin compared to glass. All the glass ones, at least reported, are above 30 gray. The resin ones, there have been anything from 15 and up.
Well, and it's not just lung injury, also radioembolization-induced liver injury as well. The threshold dose for resin
for both
for background liver is lower than
the biologic effects as you go higher with the number of particles tend to happen at lower doses. That biological effect can be tumor response. It could also be toxicity. It could also be toxicity both to the liver and the lungs. Yes, 100%. So projected lung dose, not the lung shunt fraction.
Agree, disagree?
So I agree on the lung shunt stuff. I think the lung shunt is not a percent lung shunt is not a barrier to treatment. That said, a lot of high lung shunts result in a lot of high lung doses, which you got to be cognizant of. And so I tend to never go above 30 gray in a single session, and I try to stay below 50 gray lifetime. I have cheated. I've gotten very, very close to the line on both. I've probably eked over 50 gray in lifetime dose, and I've had patients do fine. That's not to say that that's necessarily the safest way to do it. There's a lot of discussion that happens on the front end and the back end with the patient, with the referring providers, if you're going to do those kind of things, because you got to understand that you're really kind of you're branching out here. In general guidance, I would say stay below 30 gray, really stay below 25 gray in a single session. Try not to ever get above that, and try to stay below 50 lifetime. You have to pay attention to what your doses are.
And keep track of them.
And keep track, right? And so that's where having good documentation in your imaging reports is critical. Some of those standardized reports are wonderful because we just go back and I reference what was my total lung dose there. So what's my cumulative lung dose now for patients that are going to need continual treatments? I think there's ways to mitigate lung shunt. I don't know if this is what you want to talk about right now.
That was my next question.
But
before you go there, I assume what you're talking about is the thresholds for glass. So what I would say
lung dose
for the lung dose, projected lung dose. Based on what has been published recently, I would like to stay below 15 gray.
For resin.
Because of those differences between the two devices.
Okay.
And I still haven't, it's hard to extrapolate the lifetime dose. Obviously below 50, but probably closer to below 30 gray. If you want to extrapolate.
Sure.
If it, in a single session, it can happen at a 20 gray. And I've had cases that have gone above 20 gray with resin and nothing has happened, but definitely I've seen cases that has happened with less than 30 gray.
Well, the space has also changed, right? Pneumonitis from immunotherapy, a lot of these patients are on immunotherapy. I think that can kind of factor into this a little bit. So I have a little bit different spin. I tend to walk up to 20 gray single session. I tend to not go for glass. For resin, usually even lower than that, to your point. But I tried not to get all the way to 30 gray. And then if my lung shunt is high, and this is a little controversial, but I tend to minimize my particle count a little bit.
Yeah.
Right?
So I think to highlight the particle count thing real quick before we talk about the lung shunt, I think the reason sometimes why we see differences in, liver dose, lung dose is because I think you wind up with a higher particle load, you wind up getting more saturation of normal tissue, whether that be liver and lung. And if you have more saturation of normal tissue, more hepatic globules involved. I think that's why you see higher incidences of radiation-related injury, because you have more complete coverage as opposed to more heterogeneous sphere distribution in normal tissue with a lower particle count. And that's not, I mean, you could pull off the same kind of thing with a higher specific activity resin dose too. You're lowering your relative particle load. So I think that kind of explains, at least that's the way that I understand it most why you see, normal dose thresholds with resin being lower than normal dose thresholds for glass, because it's more lower.
It's a function of
the particle
distribution.
Yeah.
And so, I agree with you.
And so I think that's probably why you see it the way you see it. In terms of mitigating lung shunt, I think there's 3 ways to do it. And one of them I hate, and that's to do a low-dose Y90. The reason why I hate low-dose Y90 to fix a lung shunt is because you burn lung dose in the process of trying to fix a lung shunt. So you wind up eating what your cumulative lifetime lung dose would be, trying to hopefully fix it. Most of the patients that have high lung shunts have pretty bad biology, tumor biology. And some have, I will say this, I expect when I see portal shunting, shunting into the portal vein, those are almost always associated with high lung shunt.
Sure.
I always see a lung shunt greater than at least 12%, often in the 20s. If I see early shunting or early filling of the hepatic vein, that does not always imply a high lung shunt. And so when people call me like, hey, I see early filling of the hepatic vein, should I shut this down? I'd be like, no, inject your MAA, test it out. And more often than not, I see lung shunts less than 10% when you see early filling, which seems counterintuitive. But that is associated with in my opinion, has not been associated with a higher lung shunt.
But it's vascularity. It's vascularity and not shunting, right?
Yeah.